Good afternoon, everyone. I'm Susan Jones, and today I will be giving a persuasive speech on the use of restraints in nursing homes. As most of you know from reading some of my posts this semester, I am a nurse. I work in a long-term care facility. I actually work in an Alzheimer's unit. A few of my patients actually have Alzheimer's. Others have different types of dementia, vascular dementia. Some have psychological problems, psychosis. But the majority of the time, we don't have any problems with behavior. Restraints often come into play when behavior is an issue. There are two types of restraints. There are physical and chemical restraints. And restraints were originally intended as a way of protecting residents. We have those residents who are a high fall risk. A lot of times they don't understand the fact that they can't get up by themselves, or that they shouldn't be trying to walk by themselves, and a lot of times they fall. When an older person falls, the risk of hip fracture, injury is a lot greater than it is, of course, with us. So in the past, restraints were used for that reason. Years ago, out of high school, I actually worked as a CNA through high school, and a few years afterwards as a nursing assistant. At that time, that was back in the early 80s, and restraints were more prevalent. A lot of my residents at that time were actually what we call tied into their wheelchair. That has become frowned upon because it is very restrictive. It sometimes adds to their agitation, and it's just not a good thing. Restraints, first of all, you have to have a doctor's order, and the family or the health care power of attorney has to be in agreement. It has to be medically necessary. Another thing that has gotten people away from using, or the medical professionals away from using physical restraints, is the use of chemical restraints, and that's using drugs to sedate residents, to reduce agitation. As a nurse now in the facility that I work, these restraints are highly regulated. There are very specific guidelines as to how and when they can be used, and we go to all lengths to try to avoid the use of restraints. I have just a few residents who are high fall risk, and we have implemented a program called the 5 Ps. Basically, there's a sheet put in their rooms, and you check on them each hour to make sure that they've been pottied, they have their personal items, they are not hungry, those kind of things. But the thing that works best for me is one-on-one attention. When a resident is becoming agitated, we, in the Alzheimer's unit, we have always had the risk of elopement. We are a closed, locked unit, and there are areas that the residents can walk safely, but yet not escape. But we use one-on-one. I find that if you just sit down and try to redirect a resident, hold their hand, just let them know that they're safe and they're loved, to make sure their needs are met, that a lot of times those situations can be avoided, therefore taking away the need for either a physical or chemical restraint. We use different types of drugs in the event that we have to. We use benzodiazepines, we use narcotics, we use anti-anxiety agents. The bad thing about that is the side effects. It usually will produce a stupor, state within about an hour. And we do go to all lengths to avoid having to do that. If a resident is a high fall risk and they have a wheelchair, the restraint of choice now is what we call a lap buddy. It's basically a little, like a little desk that you set in their lap. It just reminds them not to get up. They are monitored heavily. Another thing that we use are bed alarms, chair alarms. If a resident starts to move, if the pad is placed under them, and if they start to move, the pressure is released and an alarm will sound and someone can get there in time to keep them from falling. On a rare occasion, we do have residents who become a threat to themselves or to other residents, and that would be the main reason we would use a chemical restraint. And there again, we have to have a doctor's order and the healthcare power of attorney has to agree. If those things don't work, then we basically have to call 911 if someone is threatened. Then our resident will be taken to the hospital and evaluated in the psychiatric unit. Restraints can be useful to prevent injury to residents, but they do have to be used cautiously. And I want to just make sure that everyone understands that fact. There are pros and there are cons. And when I'm on duty, I do the best I can for my residents to make sure that we don't have to use physical or chemical restraints. Thank you.